Good morning, everybody, and welcome. If you could grab a spot, and I wanted to take a moment today to introduce Tom Cornwell. He's a physician who practices at Northwestern, and he's also the CEO and founder of the Home-Centered Care Institute. He founded Home Care Physicians in 1997, and he's made over 33,000 house calls. His innovative care has received numerous awards, including the first ever House Call Doctor of the Year and the Arnold P. Gold Humanism in Medicine Award for the most caring, impactful geriatrician in the country. Dr. Cornwell has received extensive local and national media attention, including features in the New York Times, Time Magazine, and PBS. And he was named in 2017 to the top 100 most creative people in business for bringing healthcare into the home. In 2012, Dr. Cornwell received a large philanthropic gift to create the Home-Centered Care Institute, which is a national education and research organization whose mission is to expand house call programs and the workforce nationally. So he's here today to tell us a bit about his organization and that story. I did want to mention that we're going to have some time for questions and answer, or Q&A after his presentation. We'll have ask.epic.com opened up, so when we get to that section, you can navigate there. We'll also have a couple of mic runners if you can't wait for the ask.epic.com. So with that, I'd like to introduce Dr. Cornwell.
Well, thank you so much, Fritz, for that wonderful introduction. And I thought with the Star Wars theme here, I'd call this House Calls Awaken. Just to avoid some confusion, so I have two main roles. I am a doctor with Northwestern Medicine, and all I do is house calls about 30% of my time. But then the rest of my time is being CEO of this Home-Centered Care Institute, whose mission is to spread home-based primary care nationally and to ensure that the most complex chronically ill patients that are oftentimes homebound have access to this wonderful care that you're going to see. And the way we do that is through training, consulting, research, and advocacy. And again, I'm going to talk about some of this during the presentation, but our main thing is to try to increase the workforce so that people can get this wonderful care. And so our goals today are to discuss the why. That is what I was asked to do. And the why involves both why are house calls increasing in this country? It's not a new concept, but why are they increasing in this country? Why did Epic, with all the topics that they could choose from, choose to have you learn about house calls? I want to talk a little bit about how house calls became the why for my life, and from that, how it might become part of the why of your lives. I'm going to just briefly talk about different types of house calls, and then I get the joy of telling you how amazing Epic is in the home and how it really helps me to improve care and efficiency. And I'm just going to end with just a couple slides on wonderful partnerships that are helping to spread this across the country. And so I thought in terms of the why that I would start with a story. And the story involves this 92-year-old that I got a call from the daughter that she was out of it and not eating or drinking. Very alarming signs. I recommended calling 911, and they said they have just had horrible experiences at the hospital and they just do not want to take her. Could I come out and see her? And so I did. When I found her, she had 104.9 temperature, extremely unusual in a geriatric patient for it to be that high. She was dehydrated. I had a blood instrument where I could get her kidney function, and it showed that she was going to acute kidney failure. Her potassium was low, and so I started a hydration IV with potassium. I did not know where her temperature was coming from. And I should tell you that the quality of these slides, this was in 1994, and these came off of something called Kodachrome slides. I don't know how many of you even know what Kodachrome slides are. And that's, you can see it a little grainy here. But so what I did was, because I didn't know where the temperature was coming from, in 1994, I took the x-ray machine out of the back of our van and did a chest x-ray on her. I brought the x-ray out to the back of the van where the x-ray processor was. This was before digital x-rays. And so we processed the x-ray. The x-ray came back. The white material where the arrow is pneumonia. So Dr. Cornwell now knew how to treat this patient. And so taking down a couple pictures, I hung the hydration IV on one picture hook and the 24-hour IV antibiotic on another picture hook. let the IV antibiotic run in because you want to make sure they don't have a reaction, like an allergic reaction. I disconnected it, came back a few hours later to disconnect the hydration IV, and I told them I would see them the next morning. I want you to know, because I'm pretty proud of this, I documented all this on my Gateway laptop computer using Word templates. It had the latest, get this, 256 megabyte hard drive. That's with an M, not a G, but it was sufficient back then. But how did our 92-year-old with 104.9 temperature, dehydration, critically low potassium do at home? This was her the next morning. And I never saw, this was new to me. I'd been doing this less than 6 months. I wasn't even sure if this was ethical when I left this home because it was so new for me. Well, I have seen this over and over again, and it's because of patients like this that it became the why of my life. I could not stop doing this. And I'm sure Judy probably has some stories like this. And so when the company I was working for went bankrupt in '95, I could not stop doing this. When my wife had to support us in 1996 because I had no income, she, as the children's pastor at our church, supported us so I could keep doing this. And it's so exciting for me to be able to present this here to you, seeing 33,000 house calls later, how this persistence is really making a difference. Well, adding to the why is patient need in this country. There are 3 million homebound people in this country that need this level of care. Most of them are elderly with multiple chronic illnesses that are homebound. There are younger patients, all with neuromuscular conditions such as multiple sclerosis or traumatic brain injuries from things like auto accidents. Some have cervical spine injuries with quadriplegia. Some are even on ventilators that we are able to take care of in the home, but only 15% of those in need in the country are actually being served. There's about 1,000 providers like me that make 500 or more house calls in the country. They're represented by the dots on this map. And what you see is also 12 mostly rural states with no dots, where there's not even a part-time house call provider to take care of the homebound patients there. In order to service the entire need in this country, we would need about 10,000 providers, but I'm hoping actually places like Epic are going to develop virtual tools where a lot of this can be done virtually rather than actually having to go out to the home. Another part of the why is what I call the perfect storm. These different areas that are literally fanning the sails of the house call movement. One is the aging of our society and the chronic illness that comes along with it. One is technology, the increase in home and community-based services I'm going to talk about, payment reform, and finally the remarkable value of house calls that has been shown. And so I'm going to start about the cost of aging and chronic illness. And one of the things that really surprised me about this slide is that when you look at the 50% of the least expensive patients in this country, they consume only 3% of all the costs. But conversely, the top 5% consume 50% of the cost, and the top 1% consumes 23% of the cost at an average cost of $107,000 per patient. And these are the patients that we are targeting, these homebound patients that cannot get to primary care and have to go back and forth to the hospital. Technology is one of the huge reasons why we can do this. I say that we are mostly a high-touch service. We provide wonderful high-touch primary care, but we have the high-tech capability. Smartphones within seconds can do EKGs. Now your Apple Watch on your own can do a rhythm strip for you. Numerous apps can do things like vision testing. I can do haiku. I love haiku. I can take care of my patients from everywhere. My wife doesn't always love haiku when we're on vacations and stuff. But just thank you. How many in here are just involved in haiku? Is that something that you guys, well, thank you. Here's a big shout out to you because it really is amazing to be able in real time to take care of your patients. Labs can be done in the home, point of care testing, but also most of our labs are drawn. We spin the blood down in a centrifuge in the car that plugs into the cigarette lighter. X-rays and ultrasounds can also be done in the home. home. I can actually do more in the home than most primary care offices can do in their offices. And so going on to the third area, home and community-based services, the government has this division called long-term support and services, and that's made up of two different aspects. One is institutional nursing home care, and one is home and community-based services. And if you look at the graph, back in 1983, if you needed help from the government because you could no longer care for yourself, you had one option. 99% of dollars went to nursing home care. You had to go in a nursing home. Well, over the last couple decades, there's been a real intent by the federal government to put more money in the home and community-based services. You were talking about Finland and other countries that are way ahead of us in terms of supporting people staying at home, and we are starting to do a better job. But as the government puts more money into home and community-based services so more people can stay home, they need home-based primary care to take care of them now that they're not in a nursing home. I was told to warn you, I was given permission. I'm going to show you the next slide has some leg wounds. And if any of you do not like leg wounds, you can close your eyes now and I will tell you when they are over. And so again, I wanted to give you a slide of the value of home and community-based services. This patient had actually what are pretty superficial wounds on her legs, and the reason she had these was because her legs were so swollen from always being dependent, always being on the floor. She could not lie down in her apartment. Some people can't lie down because of horrible heart failure. When they lie down, their lungs fill up with fluid and they can't breathe, so they have to sit up at all times. Some people have horrible arthritis in their back, so they cannot lie down. Those were not her reasons. The reasons why she could not lie down was because there was 2 to 4 feet of garbage everywhere in her apartment. And so we were also talking about social determinants of health earlier, but there is no better way to learn your patient's social determinants of health than stepping into their house. And so we were able, with home and community-based services, to clean up all this. And she lived in a apartment building in Chicago, so not only was this of danger to her, it was a danger to the rest of the people in the building. It was actually the house call that made the diagnosis, and I've seen this happen over and over again. So the fourth aspect is payment reform, and in terms of payment reform, the main thing that is going on in this country is the director, Adam Bowler of the Center for Medicare and Medicaid Innovation, actually said, quote unquote, I want to blow up something called fee-for-service. Fee-for-service is when we are paid for everything we do, every visit, every procedure, every test. So the more we do, whether it's needed or not, the more money we make. The government wants to get more bang for their buck, which I also want, and so what they're trying to do is to go to value-based payments where the health system makes more by keeping people healthy, not for them getting sick. But having said that, even with fee-for-service, Medicare understanding the value of house calls has actually dramatically increased the amount of house calls. And so you can see back in 1997, and these were my same payments in 1994, I got $59.37 for a house call. And for that patient that I saw, because she was new and complex, I got a whopping $101.62. I didn't get any money for the IV antibiotic because Medicare doesn't pay for IV antibiotics in the home. And so when you hear about it going bankrupt, really with these dollars, you really could not make it. But now Medicare is paying more to try to encourage us to go into the home. As recently as 2006, Medicare dramatically, they doubled and tripled payments going into assisted living facilities. So we are seeing like over 1 million more assisted living facilities. And actually part of these increased payments, that those initial slides that you saw were actually a big part of convincing the government. I showed them all my stories and they felt that this was something that they should support. And so we are seeing higher payments, but having said that, even when you see the 2019 payments of $182, $197, for the time it takes to do a house call, even those dollars are generally not adequate to support the service. And so what we're really excited about is new payment reform that is going on that is paying you based on the value. So as you give better care and you reduce hospitalization, you get to share in the cost savings. The Independence at Home Medicare demonstration is a house call Medicare demonstration with 15 practices. It has actually been the most successful Medicare demo ever. It has 3 Ps, what the programs are, and that is you have to have some experience. You have to have 200 or more patients. The patients have to be have 2 or more chronic illnesses. Our patients average 10 chronic diseases. They have to have 2 or more ADL deficiencies. ADL stands for activities of daily living. That is things like, can you go to the bathroom on your own? Can you get up from a chair on your own? Can you feed yourself? Can you dress yourself? These are very basic things. And one of the things that I was thinking for you guys, what could be immensely helpful for us is to have discrete fields for things like ADLs, because both in terms of determining what patients qualify for these new models, but also in terms of showing the quality that your program is doing. Monitoring for ADLs and something called IADLs is something that they look for and something that Epic could really help us with. They also had to have had an emergency hospitalization in the previous year. And so where the payments go is the first 5%, we developed this, we told Medicare, you can have the first 5% of cost savings. That was probably a mistake because no Medicare program or no Medicare demo had ever saved 5%. And so they didn't even believe we could do it, and I didn't think we needed to give them the 5%. But we told them that, and the additional 80% would go to practices. So you would, by providing savings, you would get 80% of further savings for your program. Well, what were the results? There was a marked increase in quality. There was a marked increase in patient satisfaction. There was a dramatic decrease in hospital and emergency department use, and a savings of $49 million. And realize this is just 15 practices over the first 3 years that came out to $1,600 per patient. And so you're giving them this wonderful, amazing care. So the question would be, if doing house calls and their inefficiencies led to greater costs, we'd have to say, can we afford it? We cannot afford not to do this, because not only is it wonderful care, it saves money. And this led one of the biggest things, and so the 3-year Medicare demo is now in its 6th year. But it really has given us a great relationship with Washington, and there was new payment models that were just announced April 22nd in Washington. I was actually honored to be invited to the announcement, where they're actually gonna, they're talking about giving a per member per month payment for us taking care of these really complex patients, to encourage doctors and nurse practitioners and physician assistants to go into the home, knowing by encouraging us to go into the home, it'll save them a lot of money. So I think this is important to Epic, that as you see Medicare wanting to divert millions of dollars into home-based care, you know, we need Epic to go along with us. So thank you, and actually it already is, because it's a wonderful product already. And so just to show you an example of this, I was called out to see this young patient who was actually perfectly ambulatory, but he would never follow up with a doctor, and he had had 44 emergency department visits and 27 hospitalizations in the 1 year, 9 months before I saw him, and half of the hospitalizations, he spent time in the intensive care unit. He was getting horribly sick. If he had continued on this path over the next year, you would have expected 25 ED visits and 15 hospitalizations. Well, I was able to get that down to 1, which was 1 more than he had the following year. Conservatively, this saved $176,000 in that 1 year. I charged about $1,500 for my visits that year, but under this new payment system, I would actually get about $100,000 just for the cost savings on him, but Medicare would also get $76,000. Now, that is an anecdotal story, but we also have some good data. The first data came from the home-based primary care at the VA. It's the largest house call program in the country. It's in all 50 states. And the reason why we got this data is because the director, Dr. Tom Eads, was told he needed to cut the program. Why? They were spending $11,000 more sending out doctors and nurse practitioners and mental health workers and pharmacists than usual home health. And they said, we can't afford this. Dr. Eads said, can you give me 6 months to look at all the cost data? So all their 2002 patients were sent to the University of Pennsylvania, and I think what they found even surprised Tom Eads. They didn't find a 25 or 50% reduction in nursing home care. They found an 87% reduction in nursing home days, a 63% reduction in hospital costs, an overall 24% savings per veteran that was in this program. And when you multiplied the $9,000 against the 11,334 patients in the program, it came out to $103 million savings by giving the patients what they wanted, $11,000 more care in the home. Since then, the program has not only not been cut, it has grown from 11,000 to 30,000 patients, and Dr. Eads, who still is running it, would say they would like to service 60,000 vets, but they don't have the workforce. And so the last value equation I'm going to talk to you about is end-of-life care. Medicare spend, the most expensive year of life for most of us is the last year of life. In 2010, 25% of all Medicare costs were spent on care in the last year of life. In a JAMA article that came out on deaths over the last decade, in 2009, deaths at home had gone up 3 percentage points to 33.5%. 70% of Americans say when their time comes they want to be at home. Hospice went up dramatically in the last decade from 22 to 42%, and it's up to 50% now. And so that's a good sign, but ICU stays in the last 30 days of life actually went up from 26 to 29%. 29% of Americans spending time in the intensive care unit within 30 days of death, which is the worst place you want to be if you want to have a comfortable end of life. Hospitalizations also went up to 69%. Our statistics at home care physicians are much different. About 20 to 25% of our patients pass away a year. My wife has advised me not to advertise that if you want anyone to go to you. But obviously we're dealing with very sick people. We have had over 1,000 deaths over the past 5 years. 76% have died at home, 77% on hospice, and our median length of stay is 463 days, and so we are caring for them throughout that costly last year of life and dramatically reducing them from going to the hospital, and very few of our patients are in the intensive care unit before they pass away. And just to give you an example of this, I want to tell you Elsa's story. I met her at the age of 82. She had been born in Germany in 1921 and had come over here after World War II. And I got called out to see Elsa by social services, home and community-based services, because she needed to have nursing home paperwork filled out. And so I came out to meet her. I thought she knew this, but she did not. And as I got to know her, she had had 6 hospitalizations over the previous 4 months. And the hospital said, you are obviously not capable of caring for yourself. She had uncontrolled heart failure, uncontrolled diabetes. She lived and slept in her wheelchair, so she had pressure sores on her bottom that were getting infected. And the hospital said, you have to go to a nursing home. And she let me know that early in life, when she was in Germany, part of the reason why she lost her legs was because of frostbite in a Nazi prison camp. And she said to me in tears, Dr. Cornwell, I was in a prison early in life. Please don't let them force me into a nursing home at the end of life. And that is not what my goal in life is anyways. And so it was actually pretty simple. She was getting no care, in a doctor's office or anything. It was easy to get her heart failure under control, to get her diabetes under control. We got home health out that she wasn't able to have because there was no doctor to sign for it. The hospital doctor said that's not my job, and she had no doctor outside the hospital. We got home health out there. We got her a hospital bed. We got therapy so she could transfer in the hospital bed. By just being in the hospital bed, the wounds healed. Again, her heart failure got under control. Her diabetes got under control. She got so much better that we sent her to a rehab center so she could get new prostheses and walk again, actually get out of the hospital some, as well as, more importantly, she could for the first time get into her bathroom that she couldn't with her wheelchair that was too wide to fit through the door. And so not only is this dramatically better care, but over the next 2 years, the next 8 years, she only went back to the hospital twice. The second time was when her prayers were answered. She had a massive heart attack and died because she had no family because of that I obviously am not going to tell you about what happened at the prison camp. She could not have babies, and so she had no children to take care of her, and so she passed away in the hospital. It's not our goal, but in this case, she would have had no one to care for her and would have been forced into a nursing home, and so her prayers were answered. So just amazingly better care with cost savings. And so just briefly, this one slide, I'm just going to talk to you a little bit about house calls because, again, as you, and I don't have hospital, Fritz and I talked about hospital at home some, but most home-based primary care is longitudinal because these patients continue to have chronic illness, they continue to be homebound. And so you really, when you are called out to see them, you see them generally until they pass away. Sometimes they do end up in nursing homes because the family can no longer care for them. There's also transitional care programs. You might know that hospitals are now penalized for readmissions, and so some have set up these programs where just for 30 to 60 days, they do house calls on high-risk patients for readmission, and then they transfer them back to the doctor. All house call doctors and nurse practitioners and PAs have to be good at palliative care, but there are dedicated home-based palliative care programs. It's a consultative model that works with the primary care physician who continues to oversee care, but they really help with goals of care conversations and symptom management in the home. There's concierge practices where you pay an extra fee, and out of that you get house calls as one of the benefits. There's now what I call Uber house calls. I don't know if you've heard about this. Heal is probably the best known one in Southern California, where there's literally an app, and you put in what you want and your address, and it'll show doctors like your Uber cars that are in the area that might be willing to do a house call for $150. Interestingly, well, actually, I'll talk about that in a second. And then finally, I usually don't put home health and hospice on this because I don't consider it part of home-based primary care, but I put it on here just because of how much I appreciate you guys for your home health and hospice module that our health system is on now. But also just to let you know, my partner and I are 2 providers out of 1,000 in my health system. But having said that, we make up 7.5% of all the home health referrals and 12.4% of all the hospice referrals. And it just shows how important the interdisciplinary team is and the teamwork, that you need to really surround these homebound patients with a lot of resources in order to enable them to stay at home. And so one of the joys of this talk is to really thank you for how amazing Epic is. I'm just amazed at what I'm able to do. I demand, you heard this wonderful award I got as the most caring, impactful geriatrician in the country. And that is because I care and I provide the best care I can. And you guys really help me enable that care. And I'm going to show you 2 stories. Here you can see there's no better place to do medication reconciliation than in a patient's home. I don't know if you can see my Epic screen here, but that's you guys. But I want to tell you the story of Edith. And Edith's story was in September of 2014, and that date is important. She's 89 years old. She had gone in for a routine total hip revision, unfortunately had some complications, was sent to a rehab center after a lengthy hospitalization. 2 days after being at the rehab center, she was in a lift chair, that kind of, push you up. And then and then she got up and they started putting the lift chair down, but they let it go down too low. And if once you put it down, it becomes a recliner, the legs start going up, and the legs knocked her over, and she fell and had a pelvic fracture. And so she had had enough of the healthcare system. She had also, while she was in the healthcare system, had actually gained 30 pounds that was mostly in her legs. When I went out to see her, she had to have 2 full-time caregivers, enormous cost in order to be at home, and we did not know where all this fluid was coming from. The hospital had obviously had trouble controlling this fluid, and I told her it was one of 2 things. 14 years earlier, she'd had malignant melanoma, and cancer can clog up your lymphatics and prevent water from getting out of your legs, or it was because of something very rare called isolated right-sided heart failure. I knew she didn't have left-sided heart failure because her lungs were clear. That's congestive heart failure. She had no congestion. But I didn't know, was this cancer or was this heart failure. And so I said, despite the pain she was in, despite her inability to walk on her own, I said we really needed some testing done. We need a CT scan of your abdomen, and I need an echocardiogram. But this was September of 14, and Central DuPage Hospital had turned on something called Care Everywhere, that you guys might know of. And so I went in, this is my first patient that I went to Care Everywhere, and this was the screenshot from Care Everywhere, and you can see in 2013, so this was 10 months ahead of this, she did have a CT scan of her abdomen that did not show any cancer. You couldn't completely rely on that because maybe something had come up since then, but it also did some cuts of her heart that showed a markedly enlarged right heart consistent with right-sided heart failure. Her echocardiogram that was done 9 months earlier was consistent with right-sided heart failure. So Dr. Cornwell now had the diagnosis in her living room. So I aggressively managed her medicine. I had this advanced directives conversation in terms of how aggressive she wanted hospitalization. She already had PT, OT, so physical therapy, occupational therapy, and a nurse out, but we added telehealth so that I could get her daily weights, her pulse oximetry, her oxygen, her blood pressures that I needed to aggressively manage her medicines. One of the things, as she's not walking, I have people with their walker just walk in place. This does a lot of things. It prevents pressure sores on their bottom. It gets them stronger so that they can walk again. But I tell people your heart pumps fluid to your feet. How does it get back from your feet? There's no pump down there. Well, when you walk, you pump the fluid back. So I told her this would also help her swelling. Her protein was really low in her blood, and she was anemic that I knew from Epic. Again, not having to do any blood tests in the house. So I told her you got to increase your protein. We started her on an iron pill. Some of you who are physics and chem and bio majors might have heard of osmosis, oncotic pressure. When you are low in protein in the blood, you have low osmotic pressure and fluid leaks out. So we had numerous reasons for this person having this swelling. Well, in the next 3 weeks, again, aggressively managing her over the phone, not going back to see her during this time, she had lost 15 pounds. And actually, I did go back at 3-week follow-up. She had lost 15 pounds. She could walk on her own against medical advice. I wanted the caregivers to say a couple more weeks. She fired them. She goes, I don't need them anymore. And realized this is an 89-year-old. And then 3 months later, she was down to 135 pounds, back to her baseline weight, just back to normal. And again, part of this is because of all the information I was able to get out of Epic to know how to treat her. There were just 2 issues in the last 3-4 years with her. The first one dealt with a country club. I was getting the Person of the Year award by a local Rotary, and I was walking into this country club. And as I was walking in, she was walking out. And the problem with that is in order to bill Medicare for a house call, your patients can't be going to a country club. Oh, this is being recorded. No. And the interesting thing is just because Medicare knows the value of this, January 1 of this year, they've taken that requirement away. So you do not need any additional medical necessity to see a patient in the home. A true issue did come up in 2018. She developed a bad cough, a fever, and within 4 hours, I was able to have an x-ray done in her home. Because it's digital, it's sent right from the home to the radiologist. Radiologist calls me up, positive pneumonia, start on an antibiotic, and we were able to keep her home. So in the last 4 years, since her first house call, this now 93-year-old with a horrible right-sided heart has never had to go back to the hospital in the emergency room. Better care, dramatically lower costs. The second patient is a 62-year-old, and I'm not going to go through all the details, but basically, she really did not have a bad diagnosis. They were not sure if she had cancer. She had a hysterectomy. The initial slides were negative, so they didn't do any further surgery. When they looked at it closer, they did find cancer, so she had to go back and have her lymph nodes removed. Good news, all the lymph nodes came back negative, but then unfortunately, at the end of last year, she was found to have cancer again, and that it had spread to her bowels, so stage 4, incurable. Very sad story. Well, just to see if there was anything more that can be done, she went to Mayo Clinic, and then I scheduled a follow-up visit to discuss what Mayo Clinic told her the next week. Normally, I rely, she's completely with it, intelligent 62-year-old. Normally, I rely on what the patient tells me to discuss, okay, what are we going to do next? But this is the first time I've seen this. And what it is this is my encounters. And for, I've got some guests here. So normally I would see, I work for Northwestern, and so I would see all my home health notes here, my hospice notes here, any other primary care Northwestern notes here. I would see any specialist Northwestern notes. This is the first time, the one that's highlighted, I didn't even know to look for this. This is the gynecology oncologist note from the week before, as if he's part of my health system. And what this enabled me to do was to go over word for word what this cancer doctor had to say. It gave the patient great confidence that what she heard was what the doctor was actually saying. But again, this is, as someone who demands the best care, having this at your fingertips. I don't know if you guys take this for granted, but this borders on me on the miraculous that we can, a week later, have a Mayo Clinic note in my chart as if he's my personal consultant. There's a thank you there, okay? There's a thank you, okay? And so just the last slide is the future. I told you that 10,000 providers are needed if we do it the way I'm doing it right now, individual house calls. But truly, telehealth has such potential, especially in rural areas, but just everywhere, to really add to the efficiencies. And I was excited to see all this on your website, organizations that you are involved in. I think this is just a huge part. I look forward to working with you guys in terms of being very involved with the hospital at home movement, with home-based primary care, in terms of how can we work with telehealth to really improve the care of our country. And so just to let you know a little bit about in terms of the partners that HCCI has, we have training centers in just some remarkable places. I'm not going to read them off, but you can see them there. But these are all stellar institutions that have house call programs where we are training the next generation of house call providers, because as the government, as Medicare creates new payments to incentivize providers to go to the home, this is not being trained in virtually any medical school. And so we need to actually have this institute in order to spread this. I am blessed to have the biggest supporter of the institute with us here today. We are just so thankful of the impact that we're able to have because of many people. I also have my Chief Operating Officer here, Julie Sachs, and so I thank them for being here. And then just our other partners, we work with a lot of associations, Nurse Practitioner Association, doctor organizations, in order to spread this. But what I'm looking forward to out of this meeting here today is really for Epic to be a new partner as we try to bring this amazing patient-centered care that actually has been shown to have the ability of saving Medicare if we were able to scale it to the people that really need it. Okay, so that is it. So thank you guys.